section of elk with separation of the green and the red probe, indicating the gene has been separated and translocated on the chromosome. But the scoring of this is difficult. Remember, the cells are three-dimensional structures, and the chromosomes are not spread on a flat surface for you to detect. So a lot of the times, even if they are, when the chromosomes are not spread smoothly on the slide for you to detect, sometimes they will be arranged on a different dimension. And the arrangement may be seen end-on, just like vessels on chest X-ray. So the scoring of this fish probe requires expertise with cytopathologists. So right now, and this is expensive. So a lot of the times nowadays, we rely on immunohistochemistry, that we stain the tissue with a monoclonal antibody to detect the presence of these expression of the translocated gene in comparison to those tissue that it has got no expression. Now the expression is usually detected as a golden brown color on the tissue histology slide, in comparison to those negative where you have a lot of you have lesser amount of brown color, but most of the time you only see the nucleus which is stained blue. So we now have this elk immunohistochemical staining as an initial screening tool, and a lot of the times is specific enough for the diagnosis of elk translocation in terms of its expression. And but in case of duck, we can always confirm with the fish technique. So if we hit the target in patients with elk positive or elk translocated tumor, if we get the right drug, which is crizotinib, this one, and you will see an overwhelming response in patients who have received this elk inhibitor. So lots of the times nowadays we will try to look for patients, look for mutations in patients with advanced stage lung cancer, whether they have elk rearrangement, especially in patients who have EGFR wild-type tumor. We'll further look on to see if the patient could be having elk rearrangement. And if elk rearrangement is present or expression is present, then it's a good time that we can use the upfront crizotinib. And even if there is disease progression, we can rebiopsy the tumor and consider further generation of elk inhibitor. So not only is the response is good, it has been translated if we use the correct elk inhibitor, then it will be translated into survival benefit for the patients who have received the elk inhibitor. And we now have newer generation of elk inhibitor. Instead of using crizotinib, there is a second generation elk inhibitor that has been shown to do an even better job than the first generation one. Not only is it translated into survival benefit, it has been shown that the newer generation has been, the newer generation of LTKI will give a better survival benefit and lesser time to progression to CNS involvement. For elk tumor, we don't know why it's a characteristic of the elk positive tumor to give early brain metastasis, and compared to those EGFR mutant tumor. And perhaps this is an inherent biological characteristics of the ALK gene. And so that's why we are looking forward that if patients has got this, newer generation of ALK TKI available, it will help to lower the chance that the patient will develop brain metastasis, which is sometimes difficult to deal with. And you can see with time, actually a lot of these new TKI is coming to the market as being approved. And you can see the newer generation TKI. And also, we now have almost the third generation TKI, and which is even more potent than the first and second generation one. So that's why in patients who have ALK tumor, if they unfortunately progress on treatment, a lot of the times we will try to rebiopsy the patient to see if we can find newer mutations that is present in the tumor, or actually there will be transformation to other pathways other than ALK. And if that's detected, if those mutations could be detected, we can consider using the specific types of different forms of next generation TKI if that information is available. But even if the rebiopsy is not available, we will try on disease progression to give the patient further generation of TKI empirically. So, having talked about this ALK, and in clinical practice, you will see the understanding is at the present moment limited because the material for studying the ALK is limited because of the rare presence of this ALK mutation or translocation in our patients with lung cancer. So we have been trying to, in my research lab, trying to establish lung cancer cell lines from patients with different kinds of driver mutation. And you can see if we can take the samples, no matter it is surgical resected specimens, pleural fluid, or even lymph node specimen, we can try to establish cell lines. And again, similar to the situation here, I understand Professor Shi and also the laboratory here has also established a whole panel of cell lines from the local population to better understanding of our tumors, of the tumors with lung cancer in our local population, and provide materials for further study and research in our patients. And among the cell lines that we have established, we have one that is, and also one upcoming that is ALK translocated. And you can see the tumor cells, after we have taken them out from patients, we can actually grow them in culture, and also we can also clone them and subclone them so that each subpopulation from the original population could represent some of the origins of cells in the original tumor. What we believe is that tumors, although we say is a piece of tumor, it may consist of cells that could be either homogeneous population of tumor cells, or it can be a heterogeneous population of tumor cells. For those homogeneous tumors, or relatively more homogeneous tumor, if we treat them, a lot of times, or if we remove them with surgery or whatever means, a lot of times we could assume a cure and follow up for the patient. But for patients, what we believe the majority of the tumors will have the underlying cells that there is a heterogeneous population. Actually, if we treat them, we may be applying a selection pressure from the drugs. Even if there is what we call a driver mutations, after you have treated the sensitive clones, there could be the remaining resistant clones, or the clones that are not sensitive to the drugs that you have given, or the selection pressure that you have given. Then, after the patient has responded for a certain period, the certain cells in the resistant cells in the tumors, the remaining cells after treatment may grow again to become a disease relapse or disease progression. That's why we would like to use these cells that we have grown with specific molecular characteristics to study this kind of resistant mechanisms.